We have people listening on from the UK, from I think Ireland, from other countries far and wide. So I'd like to welcome you to tonight's the 7th live event from the Caribbean Cancer Portal. So tonight we have I would say, a very stacked event for you. A very loaded event, which is going to be very educational. There are going to be two main topics. So we have one alcoholic drink a day. What does that have to do with cancer by Dr. Merisa Grant? And then we have advanced treatments for prostate cancer by Dr. Jonathan Noël. But we also have some intermittent little events as well for you to just liven up the show tonight. So I think without any further ado, we'll move on. Just a little housekeeping. If everyone keeps their mics on mute, questions, we will have the questions at the very end of the session. So we're going to let both presenters fully present. If you have any questions, you can put them in the chat and we will follow them and make sure that we ask them. But at the end, you'll also have an opportunity to ask questions yourself, raise your hand, and we can go into open dialogue with our two presenters. All right, so without any ado, we're going to start with a small skit, which was organized by the public health students of St. George's University. So you can sit back and relax and watch our first little presentation, which is to do with prostate cancer. Donna, if we can share that presentation.
What happened? You all right? You look worried.
Everything all right.
Kyle, come on now. This is not the first time I see you looking like this. What's happening? What's going on?
It's, well, the dripping thing, man.
Oh, that's unusual. Maybe you should go and check it out by the doctor.
Nah, it's probably nothing. Don't want to waste them people's time.
Kyle, please. Your health is important. Promise me you'll make a call tomorrow.
All right. I'll give him a call tomorrow. Something ain't right.
Yeah? What's wrong?
It's personal. Sarah keeps telling me to go see a doctor, but
Listen now. One woman says something, because they love and they care. That's what she's talking from. So, they just worry about me. So maybe you should listen.
yeah. Oh, listen, man. I'll listen.
Yeah, man. That's the attitude. Let me drink to that.
So, your results came back. It seems that you have...
You good, man? You've been quiet all evening. What's up?
The results. They weren't good, man.
We get through this together. So, tell Sarah. You know that.
Yeah, man. Thanks. I will.
Okay. I think he finally went to get tested. He acting strange, but I'm scared. What if
Sarah, breathe. You're not alone in this. No matter what the results say, Kyle needs your support. And you have mine too. Remember that website I mentioned? It has information and resources for both patients and their families.
Yes, I understand that. What is the name of the website again?
www.parentcan.org.
Thanks. Thank you so much. Thank you for the
Sarah, I have something to tell you. The doctor said that I have prostate cancer.
Oh, Kyle. I'm so sorry. But you know what? We will fight this together. Really spoke to Kate, and she mentioned the website. And there's all sorts of information about, support that we can use.
Sir, I would not have been able to do this without you. Thank you for allowing me to go get tested.
Not a problem, babe. That is what family is here for.
Early detection and treatment are crucial in the fight against prostate cancer. Encourage men to talk to their doctors and get screened regularly. Sign up to the Caribbean Cancer Portal for more information and support.
So thank you to the public health students at SGU for that very informative and well put together video regarding prostate cancer. So the next, we're going to have Dr. Telesford in a little bit, just explaining a little bit more about where we are with the Caribbean Cancer Portal at this time. I didn't even introduce myself at the beginning, but I am Dr. Jane Noël. I'm a member of the Caribbean Cancer Portal Steering Committee and the chair of Grenada's National Chronic Non-Communicable Disease Commission. The objectives for tonight's event, and I hope we meet those. We're looking to explain, so we can all explain and demonstrate advancements in prostate cancer treatments. We're going to be discussing the current evidence relating to alcohol consumption and cancer, and demonstrate how proactive dialogue with patients regarding risks associated with alcohol intake is so important. So now I think, Lindonna, we're ready for the presentation. Perfect. Okay.
Hello, welcome to another live event of the Caribbean Cancer Portal, the CCP. I am Dr. Lindonna Telesford, a co-founder of this portal, along with Mr. John Swoop in 2021. We extend our thanks to the Pan American Health Organization for providing early technical support for the construction of the portal. This portal is administered by the Windward Islands Research and Education Foundation, based at St. George's University in Grenada. Today, on behalf of our partners, the Ministries of Health in the 6 participating countries, Antigua and Barbuda, St. Kitts and Nevis, Dominica, St. Vincent and the Grenadines, St. Lucia and Grenada, along with the Grenada Cancer Society and the Grenada Chronic Non-Communicable Disease Commission, I would like to thank you for your patronage and support, which has enabled the CCP to be a vibrant entity catering to cancer education for prevention and patient support in the Caribbean region. Our goal is to contribute to improving the quality of life of Caribbean people through the experience of enhanced knowledge, informed decision-making, and receipt of support for cancer prevention and care. We have been touching lives far beyond the region, and this year we intend to embark on new areas of focus to expand our services to the peoples of the region. Look out for updates and continue to patronize the site as we add new materials for your free access and use. Where applicable, we only ask that you recognize the producers of the content when in use at other events. Again, thank you for joining us today, and we hope you will enjoy this session. If you wish to provide any feedback, feel free to contact us via email at caribbeancancerportal@gmail.com.
All right, so thank you, Dr. Telesford, for that little update on the Caribbean Cancer Portal. So without further ado now, I am going to ask Dr. Sonia Nixon, who is also a member of the steering committee for the CCP and a member of the NCDC, the National Chronic Non-Communicable Disease Commission, to introduce our first major speaker. So Sonia, I'm going to hand the floor over to you. Just unmute yourself. There you go.
So I'm introducing Dr. Grant-Tate. Hold on. Let me find it. You're gonna have to use two means. So good evening, everyone. Good afternoon. Welcome wherever you are. I see Jessa Bradford, Noël joining from I think is in Ireland. So we've gone abroad, way abroad. I want to thank everybody for joining this very important session. I think that the number of people I've seen here today, and judging from who we've seen sign up to participate, tells us the crisis we're in as far as cancer is concerned, and the interest that practitioners have in ensuring that cancer is approached from the right way and dealt with as it needs to be. And Dr. Grant-Tate, Dr. Merisa Grant-Tate is our first speaker, and of course, judging from what she says about herself, she's very interested in seeing the end of cancer. Everybody wants to see the back of it. She's a consultant medical oncologist with postgraduate studies in radiotherapy and clinical research. She has independently covered the myriad of health services over 18 years, ranging from pediatrics, internal medicine, psychiatry, emergency medicine, and community medicine. However, oncology is her passion. She says her greatest passion comes from oncology services that she offers. She's the head of department of the JNF Oncology Unit and is also manages a private clinic in Wellpoint Medical and Oncology Center. She contributes to WHO IARC, or the International Agency for Cancer Research, CAN Screen 5 Global Project, and as a powerful focal point and she contributes as well as a powerful focal point on cervical cancer. Dr. Grant-Tate is a distinguished member of the European Society of Medical Oncology, ESMO, the American Society of Clinical Oncology, ASCO, as well as the Caribbean Oncology Diagnostic Network, EDON. She's also a published author. In 2023, she was accepted to the Cardiff University of Wales and is now a second-year student of palliative care medicine. Cardiff University, boasts a low admission of 20% and is one of the top 5 research universities worldwide. Dr. Tate recently returned from an official invitation by the government of Taiwan, where she interacted with top government and health officials, medical teams, and personnel in Taiwan. This is an opportunity for her to observe one of the world's most top 4 health systems and to improve the policy in St. Kitts and Nevis, where she practices. And so with great pleasure, Dr. Grant-Tate, whom we can't see, I invite you to give us your presentation that we are waiting.
Thank you. Thank you very much, Dr. Nixon. Good afternoon to all. Let me just start by sharing my screen so that I don't keep the process back. But it is indeed a privilege to be here and to be able to share with you all today. So thank you. Screen. Let me know when you see the screen, Dr. Telesford.
Yeah, we're
Okay.
seeing, and it's still buffering, it seems.
Okay.
So hopefully it will come up shortly. If not, I can share from this end.
Okay.
Would you like me to share from this end?
Sure. That's fine. Thank you.
Okay.
Not sure.
All right, so you'll just let me know when you want to move on.
Okay, that's fine. Thank you.
You can stop. Can you stop share?
Stop. Okay. Stop share.
Are you seeing the screen?
Yes, I am. Thank you. Okay, sorry. Alrighty. One alcoholic drink a day. What does that have to do with cancer? So I was asked to present on the significance of what alcohol actually does to what is the human, the human being in respect to the effects that it can have on cancer. As we are aware, the effects, they go far beyond what is cancer, but I guess it is in fact quite timely since it is that with the incidents that we are in fact witnessing, not just around the world, obviously around the world, but definitely within our own homes and our own communities, then this is a conversation that we must have. And particularly so because of the fact that it is in fact one of the modifiable risks that we can actually quite easily achieve. I'll go to the next slide, Dr. Telesford. Sorry. Not seeing the slide? Okay.
Now.
Okay. So as previously introduced, I'm Dr. Merisa Grant-Tate, consultant medical oncologist at the JNF Hospital, and I will not bore you with all of the other components of my credentials. We can go to the next page, sorry. Okay, so today what we're going to do is have a conversation about alcohol. And the first thing that I wanted to do was for us to basically think about what comes to mind when we think of the word alcohol, or what we think alcohol is. Obviously, for the greater part, and very much so within my practice, what I have witnessed is that there is the general concept that alcohol is hard liquor. In other words, then, if it's not one of the hard brand labels, then, that's not really alcohol, sort of way. When we speak of alcohol, then we think of what would be the interactions at the rum shops. So the bunch of crowds in terms of, the men perhaps maybe on the weekend, those who frequently visit it during the week rather, and so forth. But we basically have what is a generalized picture that doesn't necessarily fall into what is the individual use and consumption of alcohol. We consider what are the sloppy drunks, so people who are falling all over the place, not being able to hold their liquor, as we frequently would refer to this sort of occurrence and event. And we obviously think quite a bit too in terms of lack of control, because then it is considered that someone who becomes intoxicated, that, you know, it is that they lack control. We also refer to the lack of control in the regard of individuals who may not necessarily feel as if, or rather, we reference to individuals who we suspect are not able to limit themselves in terms of the frequency of use. And so then that is, you know, another common excuse, I would say, that we hear pretty often. Well, doc, you know, I mean, it's not like as if something that I have to do all the time. You know, I can control myself and so forth and so forth. We think of what would be the drunk drivers. We've seen what are the repercussions of drunk driving. We continue to see them, quite sadly so. Unfortunately, we have not seen what is perhaps the sort of legal process to be able to deter this sort of occurrence. We don't have, you know, this sort of campaigns that we see in northern countries, such as the United States, for example, and Canada, to be able to deter what is that general sense and to give what is a sense of responsibility against what is drunk driving. And then, of course, comes the legal trouble, arrests and so forth. So these are basically what come to mind whenever it is that we start speaking to individuals about alcohol. We can go to the next slide, Dr. Telesford. So why do we think that alcohol is okay? That's pretty common within the Caribbean, I would say, perhaps, you know, so that we really do not necessarily chastise what is the use of alcohol as, you know, it ought to be. Obviously, we have what is a carnival fete culture, where, you know, the party is considered to be much more grand, much more fascinating, the more free liquor or the more inclusive, you know, in terms of content and quality of liquor, top shelves, you know, and so forth. All of these are then considered to be what make a fete, along with what is that carnival culture. We have what is the cultural acceptance as well, as I said before, which is to say, generally, this is something that we tend to grow up seeing within our own homes, whether it is that it was a grandfather or whether it is that it was a father who would frequently go and, you know, have a little drink here and there and that sort of thing. And so then we do not tend to demonize what is the use of alcohol. There is a general cultural acceptance to alcohol use. There is the silent advertising. When you turn on the TV, you see what would be the beautiful European women, you know, with their nice glasses of wine. And, you know, even without thinking about it or even without realizing, this is actually a form of silent advertising. And what that does is that it generally motivates many of us to then follow suit and, you know, try and adapt to what would be much of what it is that we are seeing in terms of media and whatnot have you. And then, of course, there is the fact that there is the non-criminalization of alcohol. So just the mere fact that alcohol is not, it's not illegal for you to use alcohol. It's not illegal for you to become drunk even. The legality, or rather the illegality, and generally then it comes down to if you are caught in respect to whether it is that you drive when you're drunk, or whether it is that you drive when you're drunk, or whether it is that you have some sort of disorderly conduct for which then you are remanded or reprimanded rather, in terms of what would be the legal process. But without these things, then we have this general sense that alcohol is in fact not a big deal, that it is okay. And that is the general consensus. We can go to the next page, Dr. Telesford. So we are at what is the fact that alcohol, much of it, because there are references to what would be standard quantities or standard doses of alcohol. And I wanted to highlight the fact that while it might be standard, it is not safe. So for example, one standard drink is equal to any of the following, whether it be a 12 ounces of regular beer, which is usually about 5% alcohol. Then you have the 8 to 9 ounces. I'm sorry. Oh, okay. You have the 8 to 9 ounces of malt liquor, which would be about 7% of alcohol, generally speaking. You have 5%, 5 ounces of table wine, which is 12% of alcohol. And then you have 1.5 ounces of 80 proof hard liquor, 40% of alcohol. I'm not sure if it's possible. I wanted to just show a glass, Dr. Telesford, but I'm not seeing myself on the screen. I'm seeing, I think this is Dr. Nixon, right? And the slide, just to be able to demonstrate what exactly that 5 ounces of table wine looks like. Hello?
Yes, so you can do that. I'm going to stop share for a minute so you can do
Okay. Sorry. Because generally speaking, when we're thinking of, that glass or whatever the case is or wine, then we're thinking of a whole lot. But in actuality, this is actually quite a small glass, as you can see. And right here, then we have what is the full 5 ounces. Okay. So I say that to say that alcohol, and this is considered a quote unquote standard drink, but yet standard, but not safe. Okay. And I wanted to emphasize on that. Okay. So I'll let you get back to the slide, Dr. Telesford.
I hope you're not imbibing.
No. This is actually grape juice, by the way. Okay. So we can go to the next. Alrighty. So what happens when we drink alcohol?
But why don't you listen?
I'm sorry?
Can persons please mute so that you do not disturb the presentation? Thank you.
Oh dear. Okay, so we're going to talk just a bit in terms of the metabolism of alcohol and what in fact happens with alcohol. So once it is that we drink alcohol, which is chemically known as ethanol, then it gets into the bloodstream. We then have what would be enzymes that are principally located in areas such as the liver, the pancreas, brain, within the stomach as well too, and other organs, which are quite necessary for what is the process of breaking down alcohol. These enzymes then break it down into a very toxic substance that is known as acetaldehyde. And acetaldehyde is actually extremely carcinogenic. And this again brings us to the principal the principal matter of what is the presentation, which is that acetaldehyde within itself, which is an automatic, it is not something that will be avoided. It really doesn't matter if the drink is a hard drink. It doesn't matter if the drink is a creamy drink. It doesn't matter if it's a frozen drink, a daiquiri, whatever the case might be. But once it contains alcohol, then it is going to be broken down into acetaldehyde. And acetaldehyde, as I said, is in fact a very carcinogenic substance. And then, of course, then the acetaldehyde is ultimately broken down into other byproducts. Specifically, it starts with acetate before it is then excreted as other components, much lighter, water, and so forth. We can move to the next slide, Dr. Telesford. So acetaldehyde, as I stated earlier, it is in fact quite carcinogenic. And if you're familiar with the term carcinogenic or carcinogen, a carcinogen is simply to say that whatever substance that is in fact a carcinogen, that it has the propensity to be able to cause cancer. The picture that I opted to use, is obviously of a vial of poison. It might seem extreme, but in actuality, that is the reality of what is acetaldehyde. There are different components that are often responsible for the effects in terms of how quickly the alcohol is broken down into this carcinogenic byproduct, acetaldehyde, as well as too in terms of how quickly it might then be further broken down to be able to allow excretion. But from the time that it would have been ingested, it is in fact quite poisonous. And so then this is something that we really wanted to be able to highlight and share, because it's not just a matter of having a smooth drink. And again, it is independent of whatever drink it might be, the type of drink. Once it is that it does contain alcohol, no matter how little, no matter the quantity, once it is that it is metabolized, the ethanol, the alcohol is metabolized, then we end up with this byproduct that is acetaldehyde, and as I said before, which is quite carcinogenic. Next slide. So there are a number of factors, as I just mentioned, that come into play when we are referencing the absorption of alcohol, which has a lot, well, obviously would be a part of what is the metabolism of alcohol. We have to look at what is the ethnicity, for example. There's about 50% of the Japanese, and we suspect other areas or other parts within Asia where it is that the population, about 50% of them, do not have what is the gene that allows for them to be able to convert the acetaldehyde, which is, as we said before, that poisonous carcinogenic product, into what is a less poisonous product in the form of acetate. And so then within even what is your ethnicity, that is a factor that can have an impact in terms of how long you are exposed to this dangerous byproduct once it is that you would have consumed it. One of the other components that would be relevant would be in respect to the size and the build of the individual. Someone who is much more large in terms of essentially what is someone who is more obese, I should say, or someone with a greater BMI, then they tend to have what is a more diverse and more severe effect from what is the consumption of alcohol. And this has to do with what is the solubility of alcohol within fat. And so because of the fact that there is, not a whole lot of solubility of the alcohol within the fat, then all of this is then concentrated towards what is essentially the bloodstream. And then it has, far more unpleasant side effects that you tend to find along with the drunkenness, whether it's the flushing, the racing of the heart, dry mouth, flushed face, and all of these other side effects. And that is something that can be impacted significantly, even based on what is the size and the build of the individual. The gender is also another component. And so then because of this, the standard, and when we say standard, as we say standard, but not safe quantities of alcohol, the gender is also another significant factor that comes into play. Men, and we refer to people who would have been clinically assigned male at birth, that they have what would be a higher tolerance, not significant, mind you, but in terms of the amount of alcohol that they are able to consume compared to what is a female. And again, this is generally based around the fact that with women, we tend to have what is more adipose tissue. And as we would have explained before, as a result of what is that poor solubility within the adipose tissue, then much of this just goes directly to the bloodstream and then has what is that unpleasant effect. And so then just by being a woman, you have women who often want to compete with the men, be it in the rum shops or be it at the fetes, be it at the parties and so forth. And it's never a good look. It's never a good idea. But then also too, it puts us at great detriment, not just in terms of what is the intoxication, but directly so too in terms of the greater risk for cancers, which we'll move on to shortly. The phase of the menstrual cycle is also relevant when it comes to what is the absorption of alcohol. Generally speaking, during the phase of what is ovulation, then there is greater absorption. And so then women who are ovulating or in the pre-ovulative, ovulatory phase rather, they have what is a higher tendency to become more subdued as a result of what would be the effects of alcohol. We also have to take into consideration the contents of the stomach. The contents of the stomach, whether it is that the stomach is empty, whether it is that you would have eaten. A stomach that is empty, and we would have heard many times over, you do not drink alcohol with food. Well, we're trying to dissuade what is the general use of alcohol. So this is to say, because of the fact that you take it with food, then it doesn't make it any safer in terms of what would be the secondary effects of cancer. But nonetheless, stomach contents, that has a significant impact too in terms of what would be the absorption of alcohol. And then there are the associated uses of drugs, such as tobacco, for example, which tobacco and some of the some sleep aids, for example, that would increase the absorption of alcohol. And then we have, for example, those that protect the gastric lining and would have this lowered impact in terms of said absorption, be it in the form of omeprazole, ranitidine, and so forth. Okay, we can move to the next one. So very often we hear, but doc, what about the health benefits? And this is something that, has gone over and over. Every time I have this conversation, I shouldn't say every time, but most times that I have a conversation about alcohol with a patient, then they're quick to point out what would have been the reported health benefits, and specifically in terms of what is a cardiac or cardiovascular health benefit. So there was, in fact, a study that was recently concluded in what was December 2024, and a report by the National Academies of Science, Engineering, and Medicine made this review and what was the relationship between the moderate use of alcohol consumption and their outcomes. And then they would have prepared what was this documentation for Congress. This is in the United States. What was found was that the health benefits, and specifically that in terms of cardiac or cardiovascular benefit, that this was highly inflated in terms of the previously recorded evidence. What it found is that when it comes to the general causes of death, then in terms of what is a patient who would have had alcohol use, and this is specifically with what is moderate alcohol use, compared to what would be no alcohol use, that they were found to have just a low similarity in terms of incidence to have suffered from what would be non-fatal myocardial infarctions. So not that the report is saying that this protects you from what is a heart attack. On the contrary, it is saying of all of the things that you can suffer from, then generally speaking, when you use this, or individuals who are found to have been using alcohol moderately, all causes across the board, within all causes of death, there seemed to be no specific protection or elevation in terms of better health outcomes when it came to the use of alcohol. It was, however, clearly pointed out that the use of alcohol, though, it does greatly increase the risk of cancer. And that was one of the more significant conclusions of what would have been this particular study. You can go to the next slide. So the summary of their findings, which I just explained, but I'll go through them a bit. Again, in terms of the all-cause mortality, referring to what would have been the total number of deaths in a population due to any cause. And as I said, they found that there was no significant difference between what would have been mild use of alcohol versus non-use of alcohol. Weight changes, they did not find a specific difference between the use of alcohol in moderate quantities versus non-use of alcohol in terms of the changes in weight. They found, however, though, that yes, with cancer, that the cancer incidence is quite significant, where there is even moderate use or low use of alcohol. And in terms of neurocognition, there was no specific determination that they found in respect to what would have been decrease in neurocognition. So no, there was not a recorded increase of what would have been Alzheimer's. There was no recorded increase in terms of what would have been dementia and so forth, compared to what would have been non-use of alcohol. It's very important to point out as well that for this particular study, they ensured to remove what would have been abstainee bias. And what that is to say is that everyone who may have not been a drinker before and not be a drinker, they were not allowed to participate in that particular study. And similarly, those who may have been a drinker before, but then would have since kick the habits or not drink at all, they too were also excluded from being able to participate in this study. And so then there was no specific bias in respect to what was prejudice against the use of alcohol to be able to give the summary of these findings. You can go to the next study, the next slide, sorry. So what are some of the cancers that we see with the use of alcohol? Breast cancer, significantly so. We usually highlight and say that with what is a mere 30 grams of alcohol, women increase the risk significantly for what is breast cancer, cancer of the esophagus, colorectal cancer, cancer of the mouth, throat and voice box, or collectively what we would refer to as the oral cavity. Cancer of the liver, as we know, most of the alcohol is in fact metabolized within the liver. Over 90% of the alcohol that we drink, it is metabolized within the liver. And then this too is a contributory factor towards cancer of the liver. And then cancer of the stomach, also too notable in terms of the use of what is alcohol. And again, this is not specific to what is a moderate, a low, or what is a high use when it comes to alcohol. It is alcohol use across the board. Next slide. So I borrowed a slide from what would have been IARC, which is the International Agency for Research on Cancer, a part of the WHO, and they have the mandate of what is the necessary data collection that allow people like you and I to be able to work and to be able to know what impact does cancer and the different types of cancers, what sort of impacts are they having on our populations? And I've been quite fortunate to be able to do some work along with the IARC. But here, as you can see, much of what I would have earlier referred. So again, we have the incidence in terms of that of the colorectal cancer, which is second, cancer of the esophagus being the highest in terms of record, colorectal cancer being second, cancer of the liver being third, breast cancer at 13.3%, and then cancer of the oral cavity, and then all of the other cancers, which then make up 9%. So there we'll have what would be the gastric cancers and so forth. Okay, and this is as recorded, or rather for the data that was published, which is the most recent data, by the way, that has been published, which was given in 2020. Next slide, Dr. Telesford. So generally, whenever we speak about cancer and cancer incidence, what I found is that we as Caribbean people in particular, we tend to isolate ourselves from what is the topic. We look at it as what is a world problem, a they problem, not necessarily an our problem. And the truth of the matter is that cancer is very much present. And unfortunately, it shows no sign of what is going to be a decrease in terms of the immediate in the immediate future. At the same time, so many of the cancers, they are associated with what we would refer to as the modifiable risks. And again, the use of alcohol or alcohol consumption is one such risk. And so then for this reason, this is the purpose of presenting this slide to you so that you can be reminded of the fact that yes, cancer affects us quite so within what is our own population and definitely within the Caribbean. Next slide. So what do we need to tell patients? What's the sort of approach and conversation that we need to have with patients? Because again, it can be a very difficult conversation to have, especially if it is that we live in small communities or small countries. And we know, generally speaking, many of our islands, we know not just what would be our immediate neighbors, but quite a bit of our population on a whole. What we need to do, we need to tell them the truth that alcohol is a poison. There's no need to fancy it up. There's no need to dance around it. Alcohol is in fact a poison. We also need to point out to them the fact that cancer is the number one cause of death in 112 of the 183 countries worldwide. And this is as per WHO. We also need to remind them that cancer is one of the top 3 causes of death in 177 of the 183 countries worldwide. So again, if it's not number 1, it's number 2 or it's number 3 in the overwhelming majority of countries. And then the fact that 1 in every 5 deaths is due to cancer. And we know that, there are certainly a whole many other ways, whether it's being exposed to violence or whatnot have you. But yet here it is that out of all of these many ways to die, there's a saying that we've seen before where we see where they say, 99 or 100 ways or a million ways to die. There are so many different ways to die, but yet 1 out of every 5 deaths is actually due to cancer. And so this is a reminder that this is one of the things that we can do to armor ourselves, to protect ourselves, and to be able to change what is that conversation and our outcome in terms of within our community and within our space. Next page. So what is next? A call to action. I challenge you all, those of you who are, whether it is that you are health oriented, whether it is that you are health practitioners, whether it is that you are patients, whether it is that you are just spirited by what is the need to be able to have an impact within our community or Caribbean community to be able to live by example and for us to highlight what is the fact that we can in fact change much of what is the use of alcohol, and more specifically the cancers that are frequently associated and derived from alcohol use. Alcohol is a modifiable risk, as I said. No amount is safe, so it doesn't matter if it's a glass, a day. It doesn't matter if it's the 12 recommended ounces. Keeping in mind that once it is that you would have ingested this alcohol, then it is automatically converted into what is one of the most prominent carcinogens, which is acetaldehyde. And so this is an unnecessary, it's an unnecessary risk. That is the honest truth. And for us to be able to try and achieve what is that personal and collective responsibility. I thank you. And this is always the better option, of course, a glass of water. I have mine, by the way, or a bottle of water. Thank you.
Thank you, Dr. Merisa Grant-Tate. That was a wonderful presentation. I'm glad to see you drinking your water. My husband tells everyone he knows always, have you drunk your water? And there's no better drink. And I think that's it's a lot of food for thought, the concept. And I particularly liked where you were talking about what we conceive as drinking alcohol. That there's levels, and people be like mass drinking or rum shop drinking, hard liquor drinking, and everything else is perfectly passable. I think that's a very interesting take, and I'm sure we're going to have questions on that at the end. So those who want to put questions in the chat, please do, so we can collect them for the end. Please put your name and country by the question, so we know where the questions are coming from. So now, without any further ado, we are going to share a short presentation from St. Vincent and the Grenadines. So sit back and enjoy.
Good morning, staff.
Good morning.
How are we doing today?
Doing well, okay.
So I know it's a busy morning for everyone. After all, it's Monday morning and we have cabinet soon. But as such, I solicit your time right now because, as you know, St. Vincent and the Grenadines.
Excuse me, can I just go to the bathroom?
Yes, you may.
All right, thanks.
So as I was saying, as you know, we are hosting the Ministers of Health regional meeting this year in St. Vincent at the Sandals Resort. And as such, we are in charge of ensuring that all the health centers, they are abreast with all the relevant things that is required. All right. Also, we have to ensure that protocol is on point. And Miss Thomas, these are the names of the persons who are coming in. Those are the managers for the Minister of Health.
Excuse me, so can I just go to the bathroom again, please?
Okay, you may.
All right, thanks.
Is everything okay with him? Do we need to check on him? May I continue? Right, so we need to ensure that everything is on point because you know the Prime Minister depends on the Ministry of Health where everything is concerned. All right, Mr. Jones, I would like for you to coordinate with the head of ambulance, all right, to ensure that all the ambulances are on point from the airport, and there is an ambulance at every health center leading from the airport to Sandals Resort. All right? Okay, are you fine, Mr. Jack? Before we move on, do anybody have any questions? Any questions? All right, so meeting is dismissed. Have a good day, everybody.
I think we should have a little chat.
Yeah, okay.
You don't seem like everything is too fine.
Yeah, I know what's fine, not best is fine.
What's really going on, Shannon?
Girl, I don't know, but it's like every time I go to the bathroom, I have to go a lot, like every 5 seconds. And then it's like, when I go to urinate, it's like difficult for me to urinate. And when I do, it's like I'm seeing blood in the urine.
Blood in the urine.
Yeah.
That's very concerning, Shanan.
Yeah, and it's like also when I'm there, it's like my back, my lower back is hurting me. Yeah, I
How old
know.
are you again, Shanan?
14.
Oh, you're going to be 40.
Yeah.
Seems like if you do your prostate cancer check, Shanan, that fits the age criteria and the symptoms that you described.
Okay.
It matches, well, it's similar to those of prostate cancer. So I
Right,
think it's
right.
best for you to get checked. Do
Okay.
you know what your options are?
No, you can tell me.
Well, sure. I think that you need to book an appointment with the nearest urologist,
Right,
who is
right.
the doctor who specializes in prostate cancer.
Okay,
So I
okay.
think I will talk to him and
No
I can book an
problem.
appointment for you.
Okay.
And then you need to go and probably get your prostate checked.
No problem. Thank you so much.
Okay, so good morning, Mr. Providence. My name is Ms. Shadia Williams, a health promotion officer from the Ministry of Health, Wellness and the Environment. And can you please introduce yourself?
My name is Desmond Providence and I am from Redemption Shafts, please.
Well, nice to meet you. And I am aware that you are a prostate cancer patient.
Yes, please. I am stage 3.
A stage 3 prostate cancer patient, okay. And do you mind sharing with the audience your age?
73, please.
You're 73 years of age, that's good. So what we want to ask you here this morning is basically, what is your experience like living with prostate cancer?
Devastated. Ladies, if you love your husband, boyfriend, mister, whatever, and you respect him, encourage him, invite him to take a prostate test. Most of it, they do a blood test, and after that, the procedure go if it is there. When you do the blood test, you know where you are, how you are. So ladies, you know when your gentleman is skipping and missing certain bedroom effect. Encourage him to go and do the test. Go with him to show him you are with him to do the test. After you do that, he will get the courage, because some men out there believe they are macho men. And it's only foolish people are speaking macho thing. There's no macho thing in prostate problem. Please, my brother, check yourself. It ain't easy to pull out that money out of the hand. Check yourself. Go to the doctor. See what's wrong before it go wrong. And when you know where you are and how you are, you will know what to do in life. I very much encourage one and all who have not yet done it to go and do it. Okay? So please, this is me to you. If you feel it's a joke, this ain't no joke. The amount of problem I had with this prostate, my brother, some of you won't like it. So please go and do a test and see how you are before it go bad. Let the doctors help you, and you'll be a better person. Thank you.
Thank you.
Prostate cancer is one of the most common cancers among men worldwide. Many men hesitate to discuss their health, often avoiding doctor visits until they feel something is wrong. The thing is, prostate cancer can be a silent disease in its early stages, making routine screenings a matter of life and death. While some cases of prostate cancer grow slowly and may not cause immediate harm, others can be aggressive and spread quickly. Some men experience symptoms such as difficulty urinating, frequent urination, especially at night, weak or interrupted urine flow, blood in the urine or semen, and persistent pain in the back, hips, or pelvis. If you notice any of these symptoms, talk to your doctor about testing. A message from the Ministry of Health, Wellness and the Environment.
Very good. Thank you very much, St. Vincent, for that excellent presentation there. Another look into prostate cancer, and we very much appreciate a patient who is suffering with prostate cancer coming on and giving us his heartfelt message. So thank you very much for that presentation. We're now going to move on to our second main speaker tonight, and I would like to ask Dr. Douglas Noël, who is orthopedic consultant in Grenada, to introduce our next speaker, please.
Good evening, everybody. Jonathan, good evening, everybody. Jonathan Noël is a University of West Indies medical graduate. He, who following completion of his internship in Barbados and Trinidad, became a clinical tutor in anatomy at St. George's University, Grenada. He then UK. There he completed his core surgical training, specialty registrar trained in urology, culminating in his fellowship of the Royal College of Surgeons in Urology at Lister Hospital in Hertfordshire. He then traveled to Florida for a 2-year fellowship at the Global Robotic Institute. Following this, Jonathan returned to the UK in 2022 to take up the position of consultant urological surgeon, Guy's and St. Thomas NHS Foundation Trust, one of the top 10 worldwide centers for urology. He is a champion of rapid diagnostic and minimally invasive pathways for general urological conditions, and his subspecialty focuses on the management of prostatic, benign and cancerous conditions. He is proficient in utilizing endoscopic and robotic technology to deliver surgery to his patients and senior registrars and consultants in their international radical prostatectomy fellowship. He has an extensive research portfolio and regularly undertakes community engagement for education on cancer screening and urology management. So without any further ado, here is Jonathan Noël to talk to you on the advanced treatments for prostate cancer.
Thanks for that introduction, Doug, and it's so good to be here. I hope you can hear me okay. I'm just going to share my slides, and I'll put it in slideshow. Hopefully that's okay. I see a thumbs up. What, tell us first. Good. So, right. My name is Jonathan Noël, and I was telling Jane, you know, when they say Dr. Noël, there's just so many Dr. Noëls that we don't know who we're referring to. So, please, for question and answer, just call me Jonathan. Probably make it easier. So, I wanted to talk about the advances that we enjoy in the UK in the diagnosis and treatment of prostate cancer, and perhaps discussions will be where their place could be in the near future in the Caribbean. Because I'm not here to stand on a soapbox, and I'm not here to speak to you about what we enjoy, but hopefully inspire some people in the audience as to how we can work together so that it is a global phenomenon and not just one involved in the bigger countries. So my career journey, like Dr. Douglas Noël has kindly summarizes there, so I won't need to go into that, but I did join Guy's and Lewisham and Greenwich in 2022, so I work at both centers. Lewisham and Greenwich is a smaller peripheral hospital that really got hit hard with COVID in terms of the lost 50,000 men from the pandemic in terms of cancer diagnoses. There's been lots of late presentations since COVID, and we're still catching up. And so my remit was to do my part, small part, for prostate cancer in the smaller peripheral hospital where I work once a week. That is Queen Elizabeth Hospital in Barbados. Those of you who've been to Barbados will remember that that is the appearance of it as you walk through the door. This is where I graduated. This is where I learned surgery and was first introduced to urology by a urologist known as Jerry Emptage, who is a character, but really inspired me to take on this journey, and I'm glad that he did. This is the outline of the talk, and some of the slides may be very busy. I'm trying to pitch it to doctors, patients, or just people who are not in the medical field. So do bear with me, and please write down your questions, because I'm really keen that we have time to discuss any questions that you do have. So diet affects the prostate. Well, what is a prostate? It's a gland. It's a male, so it's only in men, accessory organ, and it contributes to seminal fluid or ejaculatory fluid health. And its role obviously is stated during the reproductive years, but as we get older, the testosterone starts to impact it, and it can change. It can become enlarged, as you see in the picture on the right. Diet can impact it favorably, such as tomatoes, green leafy vegetables, a plant or soy-based diet decreases cancer risk. Red and processed meat increases cancer risk, and not only in the prostate gland, but in other organs, and can increase your risk of cardiovascular diseases. But there's also a genetic component. So one has to be aware of their father, brothers, uncles, family history, because they have impact, but also their mother's, sister's history in regard to the breast cancer gene called the BRCA gene, because that can also impact your risk for developing prostate cancer. Plant-based diet is definitely on the rise. Some people think it is a woke generation thing, but it actually just calls on you to look at how much meat you consume. Do you need to eat that much meat? Certainly the world's meat consumption, particularly with our friends in the bigger countries like the UK and US, the meat consumption is out of control. So then they have to fast track meat production, whether it's chicken or beef, etc. And then the quality of meat changes, and these can impact our health. So, you know, lovely homegrown fruits and vegetables from the islands is something that I would say is a good thing to capitalize on, and it can actually be good for your sexual and urinary function and overall vitality, as shown in this paper from Stacy Loeb in New York. So what is PSA? You know, PSA is prostate-specific antigen. It's a protein in the blood, and what it shows is that if it's elevated, it can perhaps suggest that there's either infection, inflammation, the gland is getting too large. So it's not very specific, but it sure is very sensitive to any change in the prostate gland. So if one has had intercourse or ejaculated recently, vigorous exercise, etc., these will cause it to really go high. So it's important that when you have that blood test, that you do so with a period of abstinence. Well, why is a PSA blood test still in use? It's been in use for decades because it fulfills that good old criteria that we as doctors know is good for a screening program. So any test that we do and we want to undertake a screening program, it should be understood. The history should be understood. It should be detectable at an early stage. And the treatment of it should benefit patients before it gets to a later stage. But also the test should be readily available, should be affordable. And the risks, both physical and psychological, should be less than the benefits of picking it up early. And that's a contentious point in prostate cancer, as I know some of you may no doubt challenge me on, and you should, because the treatment of prostate-associated illnesses is not easy to digest if the risks are too debilitating. So prostate cancer is very common, and you saw on the slide by our previous speaker that prostate cancer took up the majority of that pie chart above all other cancers, and it's growing. It may be that our medical care is becoming so good that men are living longer, and obviously age is a risk factor for prostate cancer. 1 in 8 men, according to the UK figures, will develop prostate cancer, but it's twice as common in men of Black heritage, so 1 in 4, and also family history. We have a governing body in the UK called NICE. It stands for National Institute of Clinical Excellence, and it guides us on screening. Men who are at risk for prostate cancer or who are not at risk for prostate cancer are not advised to get screened in the UK. So it's something that patients have to drive by asking for a test. And it's a conversation that you'll have with your GP about the pros and cons, but GPs do not necessarily need to test for PSA because the thinking is the overdiagnosis and overtreatment is not worth picking up these diseases early. And I'll explain why later on. This chart just shows on the broken line the impact of the pandemic. The broken line is prostate cancer. The other lines are different cancers, lung, colon, breast. So this drop coincided with COVID. Like everywhere in the world, there was a hesitation, or I suppose a mandate that you don't see your doctor face-to-face unless it's an emergency. So then we obviously felt the impact of that after COVID. A lot of men were actually not presenting out of fear or just didn't present at all. And we're seeing a lot of late stages now in prostate cancer. But say you have a PSA blood test and you get referred to me, I would even consider biopsying you because a scan will tell me whether I need to or not. So an MRI prostate, which is something that we do in 10 minutes without any injection. It's something that we're really trying to get to be very cost effective. I think the cost in the UK now is £150 for the scan. But I do think it is worth it because when the gentleman comes with a high PSA and the scan is done and it's normal, never come to a biopsy, off you go. I will check your PSA in another few years, and if it's up, we'll do a scan. If it's the same as it's been, then no more scans needed and no biopsies, and don't need to trouble you. And I think this eliminates a lot of the unknown that currently is the state of play, I know, in the Caribbean, where we don't have readily accessible MRI scans. So the men have to have a biopsy to have some assurity, and the biopsy can carry lots of risks. This limited MRI availability worldwide is being considered by colleagues now. So this is a paper that is fresh out the press. You can see at the bottom, published online March 23rd, 2025. So today, I'm giving you this information because colleagues from Canada in Toronto are not satisfied with MRI availability. And, you know, Canadian healthcare system is really good. I know got some cousins over there living over there and enjoying the healthcare system. They're very pragmatic. They don't want to throw millions and millions of dollars without having a rational alternative. And for them, they're not happy with MRI scans. So they've evaluated the use of an ultrasound to see if it's the same as an MRI in terms of pickup. And today they published and said, you see on the right of the screen here, that an ultrasound scan can pick up the same percentage of cancer as an MRI can, 46% and 42%. Isn't that amazing? I was so pleased to see this, and actually it was done in studies in centers, across the world, 20 medical centers, none in Caribbean or Latin America, but obviously they're trying to be global in this message. And I've already been having discussions with colleagues in the Caribbean about how we can investigate this. Because an MRI is not a cheap test. And if the MRI is normal, then what do you do in the future? You may need to repeat another one. I think the health economics have to be understood. And an ultrasound scan proposes something that's not inferior. So it's no inferiority to MRI as from that study that I've just shown you out of Toronto. If the MRI showed something, then yes, you may take a step back. Those men in the Zoom are probably holding their breath right now as they see this picture. It's a ultrasound probe in the back passage, a needle through the back passage to biopsy, and antibiotics are mandatory before and after, because you can imagine that the risk of infection is quite high with this approach. In my hospital or in my sector, we've gone away from that now. We will never put needles through the back passage ever again, because we don't need to give antibiotics now. And our risks of infection and coming back into hospital are pretty much eliminated by putting the needle trajectory directly to the skin, to the prostate, rather than through the back passage. And you would think, why did we think about this decades ago? We just didn't. We just thought it was easily accessible through the back passage. And I've taken care of patients who've really become ill by a biopsy through the back passage. And, you know, for the past 200 cases, we've done it without antibiotics in my hospital. And it's shown no difference so far, but we are checking and making sure, because it's something that I think anybody who has antibiotic resistance as a country, as a region, should explore. And we call it transrectal exit, so like Brexit. So that was a joke, I suppose, on the whole Brexit thing, if you follow politics in the UK. This is another one hot off the press again. I think there's, you know, you see me saying hot off the press 2 more times, because I am missing a big urology meeting in Europe, in Madrid, in Spain, to be here with you all. And I'm very happy to be here with you all, believe me, because Heathrow Airport had a fire and all the planes had stopped. So it's a traveling nightmare for anybody going to Europe right now, or coming to the UK for that matter. This paper actually showed that the traditional way of doing the biopsy through the rectum and the new kid on the block doing the biopsy through the skin to the prostate showed good cancer pickup. This was a randomized controlled trial, so this is level 1 evidence, 1,000 patients, 10 centers in the UK. And all had MRIs, but the people who had biopsies through the rectum had antibiotics. The people who had biopsies through the skin or perineum had no antibiotics. So that's a pretty important point, although they brush over it at the end. And the infection rate, 0.2% through the skin and 1.2% through the back passage. But the cancer pickup rate was the same. Limitations of the study, no London centers, which means the diversity was very limited. 93% of patients were white. We know that in very congested areas, such as London, with a diverse patient population, we can get antibiotic resistance. And so, you know, this study had some merit, but I don't think it's ready for our global application. But the author of the study is one of my colleagues, so we're all congratulating him, and hopefully we'll get to work on proposing it for a Caribbean study. I have to be careful of time because I do waffle on a bit, and just let me know when I'm near the end of my time.
You're all good so far, Jonathan.
Cool. So active surveillance. So say you get diagnosed with prostate cancer and it's low risk, it's a puppy. Well, we watch you, we don't treat you. We know that we can watch you and there's no risk to you developing any progression once we keep track of your blood tests, PSAs, etc. And the uptake of active surveillance is actually 95% in the UK. Not so much in the US, but I think in a different environment where there's a little bit more bang for your buck, shall I say. There's probably other reasons swaying doctors to ask patients to consider being treated early. Side effects of radical treatment. So to have your prostate removed, to have radiation treatment, they will give you side effects. The prostate is the holy grail of the man's ability to hold his urine and to have erections. It is the focus of those 2 things. And so any treatment to it, whether it's for a benign enlargement, whether it's for cancer, will impact these things in some way, shape, or form. And like the patient from the St. Vincent and Grenadines video said he pleased to, the partners of said patients to really kind of hold patients' hands through this, because it's not easy, and masculinity is obviously different to different people, but surely, going through the treatment has to be considered very carefully. So robotic surgery is something we'll just touch on quickly. Open surgery is another way to remove the prostate gland. Robotic is what I use. I think it's a revolution in terms of getting patients out of hospital the same day or the next day, and not needing any blood transfusions, and very low risks to patients. And radiotherapy is also a very good option. So what's a robot? It doesn't mean I switch it on and I go and have coffee and do a ward round and come back and the operation is done. I have complete control. I sit down by the computer on the left. The robot is attached through tiny little keyhole ports on the man's tummy. And I have complete control and very good vision. So the prostate, you can see, looks like a little tangerine underneath the bladder, and the little yellow spaghetti is the nerves, and you try to just peel off the nerves and preserve erectile function for that man. And of course, you could imagine the earlier we find a cancer, the better or chance of preserving nerves and function. Little video here, just sped up quickly. So the top left screen is how it looks like from the inside. Top bottom on the left is me playing around with the recorder because I was demonstrating to some students who were dialing in. Top right is my assistant, Gabby from Spain, and she has the ability to pass needles, sutures, etc. And the robot is docked and off you go. The patient's in a head down position, so the head is at the bottom, the feet are up in the air. And the bottom right is just a picture that we used from somebody doing graphics just to recreate the image. So we use this information. We're a teaching hospital, and we like to obviously see if we can help students through this. I'm sorry? I thought I was getting a question there. Okay, so I will move on from that. This is another kind of video just to show you that, just outside of the room, you can do the operation. And some people are testing it to be in another country now. So there's a Chinese robot that allows people to operate on patients from overseas. So obviously it takes a lot of coordination, takes a lot of trust with the local team, and then trust with a foreign surgeon to actually allow this to happen. But it's our kind of exporting expertise overseas with technology. So the same way we're able to all get together on Zoom and share knowledge, which is something that, we'd probably have to fly to each other's respective countries to do. Now we can actually share perhaps tips, guide, mentor, etc. I think telecommunication guided surgery is something that hopefully in my career, my lifetime, will become a reality to the betterment of patients. Now, there may be some in the audience. I know that there's some very esteemed colleagues in the audience. It's great to have you listening to me for these few minutes as I close up. Open surgery versus robot surgery. Well, what's the difference? The age-old argument was, why spend all this money on a robot when I can do it with open surgery just as well? Well, this study sought to answer that question, because this was a study done in Brisbane in Australia. You know what the Aussies are like, very forward-thinking, very no bravado. What you see is what you get. So one surgeon, very senior, very good at doing open surgery, and then a younger surgeon who just came out of the fellowship who did robotics. They compared, their outcomes to each other, not in a competitive way, but just to explore the differences. And, there was no difference. Now, you may listen to me and say, well, then what's the point of the robot? But if you may recall, a very senior surgeon has developed their craft over decades, and has been bitten once, twice, maybe a handful of times, and has really perfected that skill. Will you be willing to wait another 20 years for someone to get that good? Or can someone come straight out of their fellowship or their training and actually deliver very good care that's equivalent to someone being 20 years ahead? Well, then what's the next 20 years going to bring? You know, patients may actually get better outcomes than before. And it's not to say that this is something that is a negative. I think it is a positive. I think it's moving forward. We want to be always better and better and better. I want, you know, perhaps my cousins, nephews, my son or my daughter to be better at what I've done, because, you know, that's how we progress. So Brazil put out the same paper comparing open to robotic, and the Brazilians are really, really interesting in that they are in a transition to robotic surgery after having open, and it's a recent transition. So I really looked to them for inspiration, and they showed that the robot gave patients superior recovery of their erections, superior recovery of their continence, and the cancer control was the same. So for them, the Brazilians are sold. They're going full robotics when they can. And also the robot meant less blood transfusion, and they were out of hospital in no time, which traditionally with open surgery, I know that patients can stay up to 5 days in hospital. With robotics, most of my guys are back to their home the next day at lunchtime, enjoying their meal with their family. I'm closing up now with these little thoughts. And some may ask me, well, why bother with prostate cancer? Because this study, which is called a PROTECT study, I looked at 15 years after someone was diagnosed with cancer, and they split them up into 3 groups. People were monitored, people had surgery, or people had radiotherapy. And what was the author's conclusion? What was the author's message? The survival of prostate cancer was high, irrespective of whether they had treatment or not. And men did have metastases or the disease spread, but they didn't die. And they said that the long survival of prostate cancer, they can't justify doing a whole population-based screening at this time. So PROTECT trial is one that I suppose the antagonists of prostate cancer management use to justify, I suppose, not being screened. But my thoughts, I shouldn't say I speak for the whole family, but my thoughts, Jonathan Noël's thoughts on PROTECT is that in 2023, we've got better scans. In 2023, when this study came out, the technology is different. And that paper in PROTECT didn't recruit any London centers, and the diversity was pretty much less than 1%, as in all white British. And we know that there's a different risk profile for patients who are Black, and that may be genetic, that may be cultural in terms of not presenting on time. That's a mixed bag. But we certainly know that the UK looked at prostate cancer and found there was undertreatment of patients from Black ethnicity and undertreatment of patients who lived in deprived areas. So there is a lot of inequity going on in terms of prostate cancer care that we need to look at and be better at. So to summarize, prostate cancer in its early stage causes no symptoms. So this skit is very important, and I think pitched just right. But your guy going to the toilet and seeing blood, you know, that gentleman, unfortunately, has probably got disease that's a bit advanced. Usually it presents with no symptoms. So you must, in my opinion, discuss a test, a PSA blood test. That's screening. I think an MRI scan is worthwhile considering because it avoids all the extra biopsies, etc. If it's normal, and in our hospital, about 75 or 80% of men who have high PSAs have normal MRIs, and then they don't see me again, and they're very glad to not see me, I'm sure. No, you know, I'm not offended by that. I think it's great to give a man an MRI scan that's normal and give them the news that it's okay. And we're doing biopsies better, safer, and not using antibiotics. So that should be of interest to the Caribbean. And I think we have to be very transparent on how we do as surgeons. I recently had a meeting where we compared ourselves to other surgeons. Just a quiet, closed meeting. I won't say any more details about that, but it was very informative. And I think we live in a world where everything is out there, but we want to use it to make ourselves better, to deliver better care for our patients. I'll just leave with this video because none of this talk about transperineal biopsies, MRIs, robotics, none of this stuff really matters unless I believe you go to grassroots, which is starting at the beginning, which is starting at awareness, which is giving men a safe space to speak about their ailments. And it is not necessarily prostate, it could be blood pressure check, it could be blood sugar check, it could be anything else, mental health. And this guy from Trinidad is Kevin, who I go once a year to his barbershop to speak about my specialty interests. And he has diabetes covered, sickle cell covered. He's amazing. And I'll just play the short video that we did together just to raise awareness. I hope you can hear it. Let me make sure that you can, because there's a way for me to do this. Share computer sound, stereo.
My job is not just being a barber. It's about healing people mentally and by speaking to them and making sure that they're on the right track. You understand what I'm saying? As much as I could do. People in this community, they're very close with each other and stuff, and sometimes, you know, they come through the door and ask questions or even confiding in you by asking you certain things if I ever experienced things in my health. And I was able to unfold questions and answer from that point on. From there, started mixing doctors and also clients to kind of help each other. Started growing from strength to strength.
You know, one of the benefits I saw when I came almost a few years ago, I was invited by a mutual friend of ours from Trinidad, because we both got Caribbean roots. And he said, come along and speak about prostate cancer. Kevin and other allies are reaching out to those people who just, you know, are a bit fearful to make that first step. So I mean, the power of their reach in a community I can't be overstating it enough. It is really important, you know.
So I think what we need to do is send this message across to go and get your check.
Yeah, I agree completely. I think one in 4 Black men being affected by prostate cancer is a real humbling figure, and to not have a national screening program, you know, I think people need to relook at that, and hopefully they will in time. But information has to be shared, and this is one way, you know, through Kevin's barbershop, and hopefully other barbershops will follow suit, because, you know, I think it's an amazing initiative he's come up with on his own, and it's just growing every year.
My job is not.
So that's Kevin and me with a steel pan there, you know, which is a Trinidadian stalwart. And that's me and Papa Noël there next to me in Grenada. Did a little talk there, and the local and Cuban contingency. So yeah, I hope that this was helpful. I hope that you've walked away with something. I hope you do keep in touch with me, and I'd love to come back again, or I could bring someone else and just be in the audience as well if you want to speak about other topics. So that's where I work. That's my practice on top there as well. That's a QR code, and I'm sure anybody could get in touch with me very easily. There's enough Noëls around in Grenada. Thank you.
Thank you, Jonathan, very much. That was awesome presentation. We're opening up to question time. I have a hand up, but before that, I have 3 or 4 questions that were put in the chat. So they're a mixture between for you, Jonathan, and for Merisa. So I have a couple for Merisa from her talk. So maybe if we start with hers. Dr. Bradford, I have you, and I'm going to come to you in just a minute. The first one, I've got a question from Satesh Bidesi. And this would be, I think, for you, Merisa. It says, what are the economic implications of implementing stricter alcohol control policies in the Caribbean? And how can public health objectives be balanced with the region's reliance on alcohol production and tourism revenue? That's a very hard-hitting question. What are your thoughts? Have any thoughts on that?
I might get put out of my country by the end of the night.
Exactly.
What you say on here stays on here.
But
yeah.
I mean, obviously, you know, the repercussions, I think they speak for themselves, you know, in regard to the just again what is much of the cultural aspect when it comes to what is alcohol use. And apart from that too, then we also have, you know, major, companies, you know, in terms of manufacturing and so forth. And, you know, one of the larger ones, for example, you know, one such thing is in terms of what is the distribution and production of alcohol. And that too obviously contributes significantly to what is our overall, you know, economical, you know, situation, and would have its impact on our GDP as well. So I think as health practitioners, you know, what we have to do is to try and lobby and advocate, you know, directly with the population. I'm not too sure. I know, for example, there have been, you know, other incentives in terms of against what would have been carbonated beverages, you know, and the excessive sugar. You know, there have been other programs, for example, in terms of against what is the importation and the use of, you know, plastic and things that, you know, essentially have what would be perhaps what may appear to be more simplistic approaches, and yet at the same time, you know, they're always so difficult to finally get into full implementation. So I'm not too certain in terms of, you know, what measures as such that I, as a practitioner, would be able to recommend. I would have to say that, you know, at best, at the end of the day, it comes down to the policymakers, and, you know, they obviously have to look at not only what is the health component, but also to the economic aspect of it. Although it is much more expensive to have to take care of what is a large group of sick people, you know, and so, you know, I think perhaps maybe that is one of the things that we can encourage, that we see what is greater investment towards health and healthcare, and then we might be able to see that sort of change.
Thank you. And I'll ask you another question here, and this is quite an interesting one. This is from Sherry Ann George Smith from BBI. She's Grenadian heritage. And she said her parents, she grew up with parents, grandparents, elderly relatives, saying that before a meal should be taken, a shot of brandy, rivers, or claps.
Culture.
And she said she has a relative of 99 who still does that. So she said, how would you address those cultural norms? If you have a patient diagnosed with cancer who is drinking and drinks like that, how would you address that?
Again, it comes down to, I mean, it's difficult, but then it comes down to education. I think if we, you know, we try and plant individual seeds, we perhaps would be more successful. And that is why it is so important, not only for us to function on the basis of health practitioners, but also to as active members of our communities. Many of the messages that I try to share and so forth, I mean, I can only see so many patients. And so then, you know, I have to be able to depend on what is my community, you know, and all those around me to keep that message going, to keep sharing, to educate and so forth. So I would say it's perhaps not something that we will be rid of, you know, in the course of what is one generation or the next. But, you know, if we make our starts as of now, perhaps then maybe within the generations to come, and hopefully not too many generations far off, then we may actually have what is that, you know, that desired change.
Yeah.
Can I make a point here, please?
Yes, Sonia.
So, Sonia Nixon from Grenada. Look, in as much as we consider cancer as a public health problem, the root of cancer, and in this case, alcohol use as a predisposing factor, is a big public health problem. I'm sure a lot of us were introduced to a lot of new concepts and information here tonight. And if we don't know, try to imagine how much less the population knows about the risk of alcohol and cancer. And therefore, how do we mitigate? Of course, by education, health promotion, health education. Certainly, we have to do this. The thing is, we probably produce 1% of the alcohol, although we produce the best alcohol in the world, they say, in the Caribbean, in the West Indies. However, we consume 40% of that. We drink 40%. How much of the profit we drinking? Think about it. So we're going to have to, from a policy, from an economic standpoint, revisit this whole alcohol consumption thing, because we're seeing now it's affecting, we didn't recognize it, our health bill even more than we had previously anticipated, right? The bottom line is that we are going to have to structure public health education about how alcohol is affecting our population as a predisposing factor. About 5 years ago, the Brits had produced a paper on breast cancer in young women, where they showed alcohol as the biggest risk factor to these young women, I'm talking only very young women, having breast cancer, where they showed how alcohol was the factor that determined, okay? Alcohol was the determining factor that these women are consuming a lot of alcohol. It's the things that we're going to have to act together and figure out how we're going to approach as people who treat, who worry about, who try to prevent whatever, prostate cancer, whatever form of cancer. We're going to have to introduce alcohol as the other enemy. Yeah. Forgetting cultural norms and all the rest of stuff. We're going to have to tell our population what the truths are. Thank you.
Thank you, Sonia. Now I've got a couple of questions for Jonathan, and then I'm going to come to Dr. Bradford for his question. One question is, Jonathan, you had mentioned like fresh fruits and vegetables in the Caribbean were a very positive thing. And a good diet, if we're looking at a diet that helps reduce the risks of prostate cancer, as opposed to so much meat, et cetera, et cetera. And an interesting question from Mr. Clement George was, what do you think, do you have any proviso with regard to these dietary recommendations, considering the amount of pesticides and herbicides used in the industry and being sprayed on in Grenada? Have you got any comment on that?
Yeah, I think you should try to avoid all fruits and vegetables that are from that. So it depends on where you're sourcing them from. I think things should be responsibly sourced. But equally, that is not on the flip side an excuse to then forego that and have meat, because I can tell you that the production of beef is horrific, particularly if you're looking at the US and the UK at large. Chicken, hormone injections to get them growing faster. Even fish, farmed fish, which is not a problem, but in the Caribbean, but certainly in the UK, I really hesitate to have fish sometimes, because I don't know where the source is from. So, I think there's risks whichever side of the coin you're going to get your food from. So getting it responsibly sourced, or like one of my best friends does, he's got his own little patch where he's growing his own fruits and vegetables in the back of his yard. That may be something to consider.
And then I have Dr. Satish Videsi again, but this is for you, Jonathan. He's saying, how do patients' attitudes and perceptions towards robotic surgery differ in the Caribbean, do you know, and compared to other regions? And what could possibly influence the acceptance of this kind of surgery?
That's a really great question. I suppose it's just new. There's not much experience with it. I can show some videos, etc. But I think until you actually see it, it's a different ball game. So I'll give you a real life example of a senior house officer who came from Barbados. He's actually the son of a anesthetist, Jordan Fakuri. He won't mind me saying his name because he's posted his visit recently online and what he took away from it with me. And he was completely naive to this kind of technology, bright spark. But he came to consent the patient with me, and the anesthetist said, "Well, do you need to know the blood group?" I said, "No, I don't need to know the blood group because I knock wood, and never had to give a blood transfusion. We'll just proceed." And I think he actually stopped me. He said, "Are you sure, Jonathan? I mean, I'm not saying, don't know what you're doing. Are you sure? Are you absolutely sure?" He had seen so many scenarios in his hospital where, you will be going to intensive care after this surgery, where you're going to need a blood transfusion, etc. And he was just shocked to have the patients go home the next day with touch wood, and it continues to be like that, minimal morbidity. And his mind has completely changed. We've been keeping in touch. He wants to grab hold of that experience and technology to bring it back home with his whole ambition. So I think it's just getting the word out there, perhaps getting key stakeholders to visit the sites that do robotic surgery, to see what the benefits can be for patients, getting patients who've had it here in the UK speaking to said stakeholders, maybe a start of a conversation where things can start moving.
Thank you. Dr. Braffett, I see we've got Dr. Braffett on. You could unmute and ask your question, please.
Good evening to everyone. First of all, thanks to the organizers for this session. I think very important topics that you brought to the fore again, and also good presentations by both speakers. My questions two questions to Dr. Noël, basically. The first is, I was particularly interested when he mentioned ultrasound and the role it could play. And the question is, what additional features would one need to be able to do that is from an ultrasonographer point of view. I presume that the standard ultrasound equipment would not suffice in this diagnosis. I don't know. That's my question. What additionally would you need in terms of ultrasound equipment and in terms of the ultrasonographer's experience, or the clinician's experience, whoever it may be, that is using ultrasound in that route? Because I see this as perhaps being a very important development and a method by which much of our prostate cancer could be screened out. And the second question is about PSAs and the PSA, the standard PSA versus the percentage-free PSA. To what extent does he think one should rely or should need to use the percentage-free PSA? I get different opinions on this from different urologists. Those are the two questions.
Thanks, Mr. Brathwaite. That's a really good question. So the first one I'll answer, ultrasound. And I think Dr. Yarwood had a question about the ultrasound as well. So I'll just kind of hit two birds with one stone, if I may. So this ultrasound scan that has recently been published in the meeting is called a micro ultrasound. And it's just a high resolution ultrasound. So, you need the high resolution to replace an MRI. MRI gives you lovely pictures, can show a dark spot, which suggests there's a tumor in the prostate gland. So you need something to mimic that. And these ultrasound scans are pretty nifty in that they can get up to pretty high hertz. I think 28 megahertz was what I remember. I haven't had personal experience with such an ultrasound scan. The one that I use is a little bit low power, and I rely on the MRI to help guide me precisely where the area is. But I'd happily use, and I think I would be very adapt like other colleagues to use a more sensitive or better picture quality ultrasound to replace the MRI, particularly because MRI is expensive no matter how you cut it. And it is a transrectal, to answer Dr. Yarwood's question, it is a transrectal ultrasound, but then the needle is piggybacked on the ultrasound but never goes through the rectum. It just kind of runs in parallel, straight line into the prostate, avoiding the rectal flora. And in terms of total and free PSA, yes, there's been some studies that look at total and free PSA, but what's really changed the game for me is PSA density. I've moved away from free PSA. Most of the labs don't use it much in the UK, but it certainly does have a role depending on the setting. But PSA density may be one of the things that have really led us to decide on whether men will need a biopsy or not. And a PSA density is the volume of your prostate gland, and you divide that number into your PSA value. So if you've got a PSA of 10 and your gland is mega big, say 100 grams, then you've got a density, that's of the order of less than 0.10. And I wouldn't biopsy a man. I don't biopsy a man if their density is more than 0.15. So density is shown to be a lot better and a stronger association. And all you need to do is find out the size of that gland, and that's simple with any ultrasound. I hope I've answered your question.
Thank you, Jonathan. Thank you. Next question. I have a couple of questions for Dr. Tate Grant again. One is from Karen Lewis Bell. She's asking, is there a cumulative effect over a period of time that potentiates the risk with the alcohol?
So there is, in fact, what is recorded. Sorry, there is, in fact, what is recorded documentation as supported by many studies, including the study that I would have earlier referred to, where it does show in respect to what is progressive or chronic alcoholism, as we would deem this term, which is to say they are no longer naive when it comes to alcohol consumption. There is also to that subgroup of what we would then refer to as the social drinkers. Then we have what would be the moderate drinkers, and we have what would be the chronic drinkers. And what has been shown is that even with what would be the social drinker, then you have what is an increased risk. And so then it is accumulative in the sense that every time you graduate, dare I use that word, to what is a new subcategory, then your risk also too increases. So yes, there is significance in respect to what is the chronicity or the long-term use of alcohol. But yet at the same time, even with what is the minimal use of the alcohol, then the incidence of the reported cancers are still quite largely noted. Specifically, the increased risk of what would be the cancers of the mouth. So in other words, then, or oral cavity, I should say, oral cavity, where you have what would be included the larynx, the pharynx, and the mouth itself, then these are found to have more significant incidence in what would be the chronic use of alcohol, and not so much so in terms of the moderate or light use. Compared to, say, what would be the breast cancer, for example, again, in the female species, because yes, we know that you can have, and there is actually, although a much reduced risk in terms of breast cancer in men, but it's still actually quite existent. And so then it is highlighted that even with what is the most minimal of use of alcohol in females, then there is that increased risk of breast cancer. And that too has much to do in terms of what's the effect on the hormones, specifically, the estrogens in particular, that alcohol also too then directly affects, thus leading to this increased risk of breast cancer.
All right, thank you. We are coming up to time, but just a couple more questions. I had one from Clement George, again for you, Merisa, which was, since alcohol is naturally produced in the body, and it's also present in some medications. From a public health pragmatic perspective, what is the best recommendations one could provide for community members?
I'm not sure that I understand the question. Sorry, if you could just repeat again. My apologies.
I don't know
I
if,
heard it, but I'm not sure if I follow it.
yeah, I don't know if Clement George is on, would want to.
Right, if you could expound maybe.
Expound on
Right.
that. A little.
Mm-hmm.
I'm here actually, so thank you for taking my question. Alcohol is produced in the body, even though it's about a small amount, and also some of the medications that we have do have alcohol. So I was just wondering, from a public health perspective, what would be your recommendation to others? Because basically, there must be something that you could recommend to the public with regards to alcohol consumption.
In respect to the use of medicine, or in respect
in general, because as you said, any little form of alcohol that was injected does produce acetaldehyde, and that is a form potentially cancerous. Therefore, we need to have a message to the public.
Right.
Yeah, so I'm saying, what is your message?
Well, the message would be, I mean, obviously, when it comes to what is, medical advice, as it would relate to the use of medication, because the last thing that I would hope for is, for our audience to then assume that there is danger in terms of using what might be prescribed medication, perhaps because of the risk of what is some amount of alcohol that may or may not be contained within it. I'll give a brief synopsis of, when I would have been doing my specialty in medical oncology. My daughter, who was with me at the time, she was quite young. She was about 7 and a half. And she, made mention to me one day when I had prepared saltfish and dumplings that she did not want to have any of the saltfish because of the fact that, she was fearful that, it would give her cancer. No, the truth of the matter is that, yes, saltfish can be associated with cancer of the nasopharynx, but this is, specific to what would be certain subpopulations in what would be, I think it's Eastern India, as a result of what is, the absence of a specific gene or the presence of a specific gene. And so then, essentially, even though her concern, I can't say that it was not valid. She did in fact have what was justification. I couldn't just say, well, no, there's no cancer that is associated with the use of alcohol. With the use of saltfish. But then I think we always have to take, take a step back and look at what our general, what our population is, what is available to us, for example. What are the things that we can use? What are the things that are not necessarily, at free will to us? And so, for example, it would be easy for me to say, then, in terms of from a public health perspective, sorry? Oh, it would be easy for me to say from a public health perspective, that we should read labels and, try and avoid, substances, including medication that may contain alcohol. But yet at the same time, then I have to also be mindful of the fact that, well, in actuality, is there an alternative that this patient would be safely able to use? And so then in absence of that, then I guess we ultimately have to be able to rely on the protocols that would be put in place by our very able ministries of health. But of course, having raised what would be any specific concern, I can't say though that I am aware of any notable concentrations, in respect to what is alcohol use within preparations for medicinal purposes. But at the same time, I definitely would not discredit it. And I would say, if anything, at best, that it just would take me back to the need for investigation.
Thank you. And I think just to finish up, I see Jonathan is answering in the chat, but just so people can know, just the last two questions for Jonathan, and then I think we're going to wrap up for the night. But Yasmina Dieterville had asked, has there been a clinical discourse meeting among Caribbean medical teams to discuss prostate cancer? This is completing evidence of where clinical practice needs to be. And I think that's interesting after all the things that Jonathan has been telling. Jonathan, do you want to just expand on that just a little bit?
Yeah, the Caribbean Urology Association, of which Dr. Yarwood received a Lifetime Achievement Award last year. So congratulations, Dr. Yarwood, on that. You know, is a meeting of minds. I think it's a great organization. It's where we meet together, you know, but in terms of how we move together as a region, it's always difficult as we're separated by, you know, masses of ocean. And everyone kind of gets on their day doing things. It would be nice, in my humble opinion, to have a regional centers of excellence in different areas, and perhaps everybody gets to advance, you know, together, so that one center, say Jamaica, isn't doing all the nice, you know, fancy tech stuff, and all the other islands don't get to benefit from it. So I think that needs to be agreed upon, but you can imagine that there'll be different vested interests. Education, middle institutions will have their own way in, but certainly we need to do better. And I think patient groups, this portal, this is one way to get the word out that patients deserve to have, you know, world-leading class care and technology, and hopefully that will change within the next few years.
Thank you. Yes, I think that is a conversation that very definitely has to be had across the Caribbean. And with people like you, Jonathan, hopefully we can move that forwards a little quicker. And I see just one last question, because we are at 7 minutes past 7. And I know what time it is in the UK. You must be almost asleep. So
No, that's fine.
Yeah, and Dr. Miguel, Onika Miguel, had asked, so this is maybe so other people can see, patient who's had robotic surgery, how long would they need to be on leave before returning to work? And maybe you could compare that to if someone had an open prostatectomy, how long it would be, just so we can understand the difference.
Oh yeah, so open prostatectomy, average length of stay is maybe, you know, 3 days in the best hands, a week in probably a lengthy process. And the return to work can be a bit more protracted because, you know, heavy lifting, bigger scar, you don't want a hernia to form, depending on your job. If it's a very manual job, probably 6 weeks or so. But for robotics, you know, most patients are quite happy to go hiking within their first week, and I have to tell them to resist the urge because I don't want them to go hiking so soon. But they pretty much get on with it very quickly, and we just tell them to take it easy for at least a month, simply because we don't want it to disturb anything internally. They've had the benefit of minimal surgery, but they're still healing inside. So I think a month of gradually getting back into work is fair.
I have a question for you, Dr. Noël. Don't disappear.
I'm not. I'm here.
So here my one question to you, and you didn't mention the diversity in access to technology and all the rest of it, even within the Caribbean. What can be my takeaway I'm in Grenada, as a low and middle income country with a still kind of simple developing kind of medical service? What would you tell me as a practitioner? What do you speak of in relation to diagnosing prostate cancer? Because I noticed you did not mention DRE.
Yes. So I think the PSA test is the starting point. It's the presentation to come for a PSA test, and a DRE certainly complements it, but a DRE can put off a lot of men from even showing up to your office or my office, certainly even in the UK. So a PSA test is very telling if it's elevated. And obviously, this may not hold much water in Grenada at the present time, but an MRI scan or a super sensitive ultrasound scan will be the way forward. Now, that ultrasound scan carries a DRE ticket attached to it. So eventually the DRE will happen. You can't run away from it. It's going to happen. That's how we assess for hemorrhoids. That's how we assess for rectal problems. That's how we give medication to the rectum, and that's how we check the prostate. So, you know, we can't always say the prostate is the only condition in which a DRE happens. And I think that's just down to education.
Thank you.
And then you get some other kind of concerns about DRE, which we won't get into because of time.
But thank you, because I think it's something we in the Caribbean can't leave out, because we're still at that stage. We don't have ultrasonographers, not the ultrasound technology that would give us these really easy ways. People will do an ultrasound, a transrectal ultrasound. Trust me, they will. But I just wanted us to have a takeaway as to the importance of still having a DRE, because I think it is very important.
Thank you. So
agreed.
On that note, I'm going to officially hand you over to Dr. Nixon, but before I do, to just close up, but for everyone on the call, this presentation has been recorded and it will be posted very soon on the Caribbean Cancer Portal. So please tell friends about it, people who didn't come in the chat, that they can go on there and have access and see the presentations. And also this is the seventh that we've had. The others, most of the others are already up on the portal. And obviously there are a lot of information on that portal. So if you are seeing patients as doctors, medical people, please direct your patients, caregivers, those with family who maybe have cancer, those who are diagnosed with cancer, please direct them to the portal, because the idea is that this will give information, very important information for these people. All right, so with that, Dr. Nixon, can you just give us a 2-minute roundup, because we are...
Oh, it's going to be less than that.
Definitely out of time.
Yeah, I know it's been Sunday, and I want to thank everybody who spent their Sunday evening with us. Thank you especially to my colleague presenters, Dr. Noël and Dr. Grant-Tate. Thank you for giving us Sunday evening, to the 200 of us who sat in this presentation today. So I think what happened this evening is that you change our concept of alcohol from that thing that makes us feel nice and high, and you know, we're ready for it when Carnival comes and everybody has a drink when they have a party, and it's okay to drink. But even Harvard's study says that they still, you know, the evidence is still out as to whether there's a healthy drink, whether one drink is healthy or not, because they have not had enough evidence to prove whether or not consuming alcohol outweighs its possibility for its carcinogenous potential. So we know that there is a new thought we're going to have, new information to share with our patients, because there is another modifiable factor when it comes to the genicity of cancers. We have looked at how cancer does in fact increase the prevalence of cancer, of how alcohol increases the prevalence of cancer. We know most of the people who have cancers do have a high incidence of consumption. One of the things I didn't hear today and I was looking for is its relation to smoking, because it's like another Bonnie and Clyde situation. Psyche and Trim, when they get together, they behave even worse, and then one of them is alone in relation to cancers. So the truth is that alcohol is a poison to us. We know that cancer care is expensive, and we know that cancer deaths is among the highest among our population. In some countries, it is the primary cause of death. When you look at other countries, it may be second, but in the Caribbean, you know, it's lurking at the top, certainly in Grenada. Okay, and this is time for call to action for knowledge, call to action for information, call to action for time to be advocates, so that governments can change the policies, create whatever is needed to create it so that people consume less alcohol. Dr. Noël, your thoughts today were interesting because I tell you, as a young physician, and I see you running to the technology, which is great. We know that prostate cancer is our #1 cause of cancer death with men in the Caribbean certainly, prostate cancer. We know that we still have to convert our population to screening early, as shown by the your short video and other video that came in between presentation. I hope that you'll be back in Grenada with robotics soon to help us to, since the turnover time is so low for healing. We, however, again, thanks for showing us how much we need to be advocates for technology that makes easier diagnosis, more specific diagnosis, more sensitive diagnoses, and for technology that will ensure that people will get screened earlier because it's not as invasive or scary, and that the possibility for long life, for longevity is existent as a result of early interventions. So thank you to both of you. Thanks to St. George's University for supporting us this evening, and Dr. Telesford for her hard work, Dr. Jane and Doug, Noël. Thank you guys for being here. And I want to tell everybody that Jane and Doug and Don and Jonathan are related. Doug is Jonathan's uncle, right? Right, Jonathan? Tell the world. You can't.
Yeah, that's
right. In medicine.
That's right.
So thank you.
Right.
Thank you, guys. And thanks. We'll be back soon with another message. Please take the message out there. Please keep reading, guys, because the information is all there. Thank you, everybody, and have a safe night and a great week. Spreading the message on prostate cancer and alcohol related. Dr. Grant-Tate, thanks a lot. See you soon.
Thank you.
Thank you.
Thank you.
Sonia.